talk about a very important guideline, that is Green Top Guideline number 75, which talks about cervical cerclage. Now here we have got the classification of cervical cerclage, which is mostly performed in a singleton pregnancy. Now the type of classification is very self-explanatory, as in what is the indication for performing a particular type of cerclage. This is very easy to remember if we understand the important concepts and tricks behind the particular type of cerclage. Like for example, a history based or history indicated cerclage is nothing but something which has a very significant history for which the cerclage is performed. So this is a prophylactic cerclage, that is, it is performed in an asymptomatic lady who has a very significant history of 3 or more previous pregnancy losses, that is preterm labor and second trimester fetal loss. So anything 3 or above, which is a preterm labor or second trimester fetal loss in the previous pregnancies, becomes an indication to perform a prophylactic cerclage in this time pregnancy. Now, what is so special about this particular cerclage is that it can also be done preconceptionally, that is, even before the lady gets pregnant this time, when we know that she's got already 3 previous losses, we can perform a preconception transabdominal cerclage, which is mostly done in cases where the transvaginal cerclage has not been successful. We will discuss about the approaches to cerclage in the next video in detail to make it clearer, but for now we can remember that this cerclage is done in these cases of significant history, prophylactically, in an asymptomatic lady, either preconceptionally or in the first trimester, somewhere around 11 to 14 weeks. So we all know that 11 to 14 weeks is the time for the first trimester ultrasound, that is the NT scan and the aneuploidy screen. So before we do the cerclage, it is very important to rule out any congenital abnormality in the baby. So after the scan and screen is done, if everything is all right and history indicates that the cerclage is needed, we can do it in between 11 to 14 weeks in the pregnant lady. Now, transabdominal cerclage has a lot of aspects to it, because when we're doing it preconceptionally, it does not interfere with the fertility, etc. We'll discuss it later in the next video properly. Now, apart from this, we all know that it is an asymptomatic lady, so the cervix is not in labor, the membranes are intact, everything is just like a gravid uterus who's not in labor, pre-labor, nothing. No question of labor when we're talking about history, because it is prophylactic. There is nothing which is a symptom in this lady. So this is the important aspect of the history indicated cerclage. Only this lady's history is significant enough in this case to perform the cerclage if the first trimester screening is normal. And these patients with the significant history of 3 or more previous losses needs to be referred to a consultant or a specialist in prematurity clinic, and a referral should be in the first trimester itself, so that at the correct time the scanning can be done, aneuploidy screening can be done, and the cerclage can be performed right in the right time between 11 to 14 weeks. So this is all about the history indicated prophylactic cerclage. Very, very easy to remember. Next we come on to the TVS indicated or the ultrasound indicated cerclage. Now here what we do is the cervix in this patient who has a history of preterm labor or second trimester losses, that is, this patient has a significant history, but on ultrasound surveillance the cervix has now shown shortening. It is less than up to 25 millimeters. So apart from the history of losses, we also have this ultrasound finding. So now that means the cervix has already started to shorten up. So this patient has a finding, though the patient is asymptomatic because this is an ultrasound finding. But in contrast to the history indicated cerclage, here we have an additional important finding, that is cervical shortening on transvaginal ultrasound. So the only two things which you have to remember for the therapeutic ultrasound indicated or TVS indicated cerclage is history of loss and shortening of the cervix on ultrasound. These are the two things that we have to remember for a therapeutic. Therapeutic is a treatment that we are giving to the short cervix. So for therapeutic, there has to be shortening of cervix, but please remember that if this is an incidental finding with no significant high risk or history, then in those cases we will not give a therapeutic cerclage. It is only for those patients who have a history of loss, who are high risk for loss of pregnancy, and they also have this finding on ultrasound, that is cervical shortening. So a significant high risk condition and cervical shortening is the prerequisite for therapeutic cerclage. So there is shortening of the cervix, and as I said, now we will discuss a little more about the high risk factors in the next video, but for now just to remember that a therapeutic ultrasound based cerclage is shortening of the cervix in a patient at risk for pregnancy loss. Now the difference that we have of this therapeutic cerclage from the emergency or rescue or salvage cerclage is supremely interesting. Now this is what makes you an obstetrician, if you can differentiate between these two. Because a therapeutic cerclage, as I said, the patient is asymptomatic. Only the history or the high risk factor and the cervical finding on ultrasound is the prerequisite. But in a rescue cerclage, the patient might have symptoms. She can come to you with a bleeding, a discharge, a sensation of something coming down, a pressure symptom. And then when you go and check the lady, there might be bulging of the membrane on per speculum or per vaginal examination, or there may be premature cervical dilatation, not active labor but premature dilatation of the cervix, which is also discovered on ultrasound or clinical examination. So the two things which are important to distinguish between the need for a emergency cerclage vis-a-vis a therapeutic cerclage is emergency cerclage patients will have pre-labor, will have exposed fetal membranes like you can see here, might be symptomatic with symptoms of discharge, bleeding or sensation of pressure. Symptomatic premature cervical dilatation with exposed fetal membrane. Fetal membranes were not exposed in the therapeutic cerclage category because There the patient only had shortening of the cervix. One more point to remember, funneling is no more a criteria for therapeutic cerclage. So after this interesting discrimination between the two, that is the therapeutic and emergency or the salvage cerclage, we can now remember and talk about the time of insertion of these two. Now time of insertion for therapeutic, it is very self-explanatory. That is when we are doing the serial ultrasound between 14 to 24 weeks. Anytime when we see the shortening, we can put the therapeutic cerclage. But emergency cerclage can be done up to the second trimester, that is 27 plus 6 weeks. That is 27 plus 6 weeks is the last time when you can do an emergency or the salvage cerclage, because it is found that on an average birth can be delayed by 34 days if we do an emergency cerclage, and there is 2-time reduction in the chance of birth before 34 weeks. So in nutshell, what we are doing is we are giving the pregnancy a little more time. That is 34 weeks is important, and this 34 days is important. 34 weeks, delivery before 34 weeks is almost 2 times reduced, and the average delay by an emergency cerclage is around 34 days. Now another very interesting form of cerclage is the reinforcing cerclage, which is performing a cerclage in a gravid uterus where there is already a cerclage. Now this is not a very common practice, but there are few conditions where we can consider reinforcement cerclage, like for patients where there has been a history based or ultrasound indicated cerclage, but on individual basis, as the clinical condition of the patient might be, we can consider reinforcement cerclage in few individual cases. But if we talk about a history indicated cerclage, USG indicated cerclage is not routinely recommended. What I'm trying to say is, suppose a lady has undergone a history indicated cerclage. Now it is not recommended that we will do routine ultrasound and then we will observe the length of the cervix and then again put a USG indicated cerclage. This sort of a reinforcement is not at all recommended. That is, for patients who have undergone a history indicated cerclage, we will not ever do a USG indicated cerclage in that pregnancy. That reinforcement we will not do, because it has been found to increase pregnancy losses and preterm births. So what we were trying to prevent will actually happen if we put ultrasound indicated cerclage on an already performed history indicated cerclage. So this is not recommended. Now suppose if there is a patient with USG indicated cerclage. Now on this patient, again already you've done a USG indicated cerclage. Now there is no point in again following the cervical length. Patient had cervical shortening, you've put a USG indicated cerclage, it is over. Now again following up the ultrasound and seeing if there is more shortening, it is not recommended. But in some cases, individual cases, we might have to do it for steroid therapy and in utero transfer. So again, this is something that we will consider only and only in special circumstances. Otherwise,